Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started.
Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. Today, we are going to be talking about patellar dislocations in dancers, or kneecap dislocations. So the patella is also known as your kneecap in layman's terms. And the reason that we are chatting about this on today's podcast is because I've seen a big increase in patellar dislocations and subluxations in the clinic recently. And I don't know if there's a specific reason for that. Sometimes in the physio world or just in sort of rehab, we kind of just go through trends of where we'll see things, and you'll see like a cluster of things all at once. And in this case, these are dancers that are like completely unrelated to each other, different genres, different ages, different like styles of dance, all of that sort of stuff. So I don't think there's any correlation, but I just happen to have seen an uptick in patellar dislocations and subluxations on my caseload recently, and figured it would be a good topic to chat about because there's a little bit of nuance when it comes to dancers and patellar dislocations. So we're going to dive in. Essentially, when we're talking about a patellar dislocation, we're talking about the kneecap anatomically coming out of its correct position. So normally the kneecap sits in this little groove on the front of our leg, and it's kind of oriented like vertically. So I always like kind of use my knuckles to visually show people if they're like in the clinic. But basically there's this little kind of like indentation or groove on the front of your thigh bone in the front of the knee. And the kneecap is actually not smooth or like not flat on the underneath side of it. It comes to a little bit of a point. Like it's almost like a little bit sort of like rounded on the underneath side, and there's a little bit of a point in through there, and that should sit sort of right in the center of this vertical groove in the front of our leg. And what happens when we have a patellar dislocation is the kneecap comes out of that groove. And in about 90% of patellar dislocations, that's going to happen going to the outside, or what we call laterally. So the kneecap's going to end up dislocating outwards towards like the outside part of like your thigh rather than inwards. In about 10% of cases, it can go a different direction, but by far, predominantly, patellar dislocations happen laterally. So the kneecap, for a variety of reasons that we'll talk about in a second, ends up going out of that little groove and popping out and into a position where it anatomically should not be. So that would be like considered a dislocation. A subluxation is a similar mechanism of injury where the kneecap comes out of like the center of that little groove it's meant to be in, but it doesn't fully dislocate. So it might shift to like kind of the side or out of position a little bit, and it may come right back in, or it may stay into that sort of shifted position, but it doesn't actually fully go over that sort of like lateral edge of that little groove in through there. So that's the difference between a dislocation versus a subluxation. And oftentimes we have people coming into the clinic and they'll be like, oh, I dislocated my kneecap. But when we actually truly assess them, they've probably actually subluxed their kneecap as opposed to truly dislocated it. And like I said, it's a really similar mechanism of injury. And in terms of like rehabilitation and things like that, it's often really similar, but they are slightly different mechanisms where that subluxation doesn't fully dislocate out of the lateral edge or the outside edge of that little groove in through there. So dislocations or subluxations can be caused by like sort of an acute force or an acute trauma. So that could be like having a collision with somebody, just some sort of trauma that happens to the front of the leg. But they can happen acutely from like sort of those forces happening from like a bad landing or like taking a step or pivoting funny or things like that. So it's not always a really high amount of force involved versus other joints in our body. So say we're talking about, I don't know, like a hip joint or a shoulder joint or things like that, and we can have dislocations that happen in those. You need high amounts of force to see a dislocation happen in a lot of those joints. The kneecap, just because of the structure of it and how it is a little bit of a floating bone in through there, so it's not really a really congruent joint like, say, the hip or the shoulder, we will see dislocations and subluxations that happen with seemingly less, or like in some cases even seemingly very little force kind of happening. And in the case of dancers, where I see dislocations happening in dancers, this is often what is happening. And so it's not usually trauma in the sense that they've had a collision or fallen on the knee or things like that, although we do see that occasionally. More often than not, somebody is going to take off for a jump or land from a jump or something like that, and for whatever reason, mechanically, something just goes a little bit wrong, and they have this dislocation or subluxation that happens. Interestingly, and I actually don't know if there's any research to support this, but when I am talking to dancers about how the injury happened and what it is that they're doing, and if you really break it down, because they'll say, oh, I was doing, whatever move that they were doing, I was doing a grand jeté, I was doing whatever. But when you actually kind of really kind of dissect it or dive into it and get them, if they can, recall, it often seems like the incident happens on the takeoff rather than on the landing. And whereas other injuries, if we're thinking about, say, a medial collateral ligament injury, like an MCL injury in the knee or things like that, those often will happen on a landing that goes wrong, where maybe their knee rolls in or something happens. But with the patellar dislocations and subluxations, when you actually kind of question them and they think back to what happened, a lot of them will say they felt something happen on the takeoff. So it's kind of happening as there's force being generated for that takeoff movement. And it doesn't have to be a jumping movement. They can happen with other movements. We see them with people doing a layout going down to the floor or things like that, where there's, force going through the leg, but it's, again, not necessarily a super traumatic amount of force, but just because of the structure of the knee and the patella in general, these dislocations and subluxations can happen. Because in dance, we're in that rotated, externally rotated or turnout position in a lot of different dance forms, I think we see a higher rate of these types of injuries than we might in other sporting populations, because the torque on the knee is a little bit different. And so in that kind of turned out position, potentially maybe dancers are slightly more vulnerable to this. Although I don't have any stats in terms of incidence rates in the general sporting population versus a dance population, I suspect that we maybe see them slightly more commonly because of that kind of external rotation or turnout position in through there. So that's the majority of dislocations and subluxations that we see happen due to sort of this force that happens through the knee, either from a trauma or from a misstep or something like that. We can also have more chronic subluxations that we see that are due to instability in and around the knee. And so we do see these commonly in dancers as well. And there's a couple of different reasons for that. So in one instance, we can actually have people who congenitally have a kneecap or their patellofemoral joint is developed in a way that leaves them really susceptible to these injuries. And so they could have something called trochlear dysplasia or patella alta, or these different positioning things that happen that has to do with their structure in that joint in through there. So there are some people who are just going to be more vulnerable to these injuries because of how that joint kind of developed when they were growing, or if they are still growing, if they're kids. Oftentimes, they're not going to know that they're more susceptible to this until they have their first dislocation. So unless there's some other reason why they've, had a lot of attention paid to their knee when they're young, oftentimes nobody knows that they maybe have this trochlear dysplasia or things like that until it becomes an issue and they have that first dislocation. So that can be one reason why we see these more chronic dislocations. So these would be people where it happens like frequently. So it's not just a one-time issue. It's something that they're like, oh yeah, every few months I do something or I go to step wrong or whatever, and like it subluxes or it truly dislocates. So that can be due to congenital reasons. We also have people who maybe are going to be more susceptible to this if they have like systemic hypermobility. So if they have some sort of a connective tissue disorder, maybe like an Ehlers-Danlos syndrome or hypermobile type, just generalized joint hypermobility syndrome, we can have people that are more susceptible to subluxations and dislocations because of their just generalized joint laxity or kind of instability in through there. So it's something to be aware of. And then we can also have these kind of chronic instabilities that happen due to repeated acute injuries. So we could have somebody who their first dislocation is due to some sort of a forceful event. So whether it was something more traumatic like a fall or something, or whether it was just those like sort of missteps, but it was an acute forceful event. So that was when their first dislocation happened. And for a variety of reasons, and it's maybe, incomplete rehabilitation or going back to activities too soon or something like that, they may then be more susceptible to having repeat dislocations or subluxations. And so each time that kneecap kind of comes out of position, there's damage that's happening to the soft tissues around it. And so oftentimes the ligaments and tendons and everything surrounding the knee are getting either, in some cases, they're getting torn, or oftentimes they're getting like really stretched out. So we get this laxity or this instability that develops because of that first acute injury, and especially if it's not dealt with appropriately after the first injury. And so then this can sort of become a pattern, and each time they have one of these incidents, they're creating more laxity and more kind of looseness in that joint, and so they're more and more susceptible. So in these cases, and we'll talk about management in a minute, but in these cases, oftentimes, especially if it was an acute dislocation the first time, and now they've had repeated dislocations, they will look at surgical interventions. And some surgeons will even have like what they call like a 3 strikes and you're out kind of policy. And a lot of the orthopedic surgeons will say, if you've had 3 dislocations after, or like from that acute traumatic dislocation, at that point, we really need to look at doing something to tighten up the structures around the knee so that it's not happening over and over and over again. So there's a few different reasons why we see some of these more chronic dislocations, and all of them have to do with instability as the underlying thing, but that can happen for different reasons. So like we said, either congenitally the structure of their knee is a little bit different, or they have some sort of generalized laxity within their system, or from these repeated chronic injuries, these repeated acute injuries in through there. So those are kind of the two sort of categories, let's say, of dislocation that we'll see. So either the acute dislocation or the more chronic dislocation. When somebody dislocates their patella, and so we're talking about like a frank dislocation, so not a subluxation necessarily, but when it's like truly goes out of place, sometimes these will spontaneously reduce. So that means it will come back into position on its own, or sometimes it's something that the like dancer will do reflexively. So you may have somebody who dislocates, maybe they fall to the ground or whatever, and they'll instinctively go to like straighten out their leg, and that will like allow the kneecap to kind of like pop back in or slide back into place. So it may spontaneously reduce due to something that like that person does instinctively to get it back into place. And in some cases that doesn't happen. So in some cases it'll still be out of position, and again, it's most often going to be off to the outside part of their leg. And they actually need to go and get that relocated by a medical professional. When I used to do a lot of work with sports teams, so especially when I was working with rugby and stuff like that, this was something that like it's actually quite an easy joint to relocate back into place. And so it's one of those things that we would actually just like really quickly do it on the playing field, like before the like athlete even came off the field. But oftentimes in a studio, you don't have like medical personnel on the sidelines. Like that's not commonplace even at dance competitions or like dance shows or things like that. So oftentimes we're looking at somebody like going and seeking out medical attention, like going to the hospital or something to have it relocated. But it often is an easy dislocation to just relocate if there's nothing like blocking it or like in the way. So it's one of those things that like when we were trained on this sort of stuff, we were trained how to relocate them, but it's like you try it, and if it's not going fairly easily, like it doesn't require a huge amount of force, or it shouldn't, then we're not going to like force it back into place. We are going to go investigate if there's maybe something like, and in that case, maybe it's actually like a patellar fracture or something that's happening in through there. So they should be relatively easy to relocate if you have like trained medical personnel who knows what they're doing in through there. But like I said, people will often instinctively, like you'll talk to dancers and they'll be like, I just like tried to straighten out my leg because it felt like I needed to and it popped back into place. And so they'll like almost instinctively do something that will allow their body to like kind of relocate that patella in through there. One of the reasons why we will try and relocate it quickly if possible, and again, this isn't always possible, but the longer it is out of position for, the more potential there is to have like significant damage to the soft tissue surrounding it. So anytime the kneecap dislocates and fully dislocates, there is going to be damage to the tissues around it. So there's ligaments that attach in, there's tendons, there's things like that. And we know that it can't kind of move out of place without damaging those to some degree. And ideally, the minimal amount of damage is better because it's going to decrease like the healing timeline in terms of the recovery and how long recovery takes. So if we can't like have a patellar injury or a dislocation that we can relocate really quickly, we've minimized the potential for damage to those surrounding structures in through there. Like I said, in some cases, it's not possible. You end up having to like go to the hospital, and ideally they're not going to make you sit in the waiting room for forever because it is a fairly easy fix, and they'll try and relocate it like as quickly as possible. But in reality, that doesn't always happen. I've certainly had dancers, and actually, in fact, growing up, I very distinctly remember one of my like classmates. We were in high school. I don't know exactly how old I was, but anyway, she dislocated her kneecap in the studio, and by the time they called the ambulance, and the ambulance took what seemed like forever to get there, and, took her to the hospital in the waiting room, like I don't know exactly how long it was, but certainly it had been out for like maybe like 6 hours or something at that point. And so by the time they relocate it, like her rehab and the healing process from that was definitely not an easy one. And I've certainly had other dancers I've worked with where when you talk to them about their experience, it has been out of position for a really long time. So in an ideal world, we do want to try and relocate them as quickly as possible. Also just because like for pain control reasons, like as soon as it goes back into place, not that your pain completely goes away because there is damage to the soft tissues, but it is significantly less painful once it's relocated than if it is like still out of position, because your body is going to try and protect that at all costs and sort of go into shock and things like that. So we really do want to try and relocate them as quickly as possible. Or like I said, in a sort of most ideal case scenario, they may spontaneously relocate on their own just based on kind of like the mechanism of how it happens. It might pop out and then kind of pop right back in. And I will say that is more common in those chronic instability, although we don't want those chronic instability because they create all sorts of other issues. The advantage, I don't know if that's the right word, but the advantage of that instability is that it's easier for it to slide back into place as well. So we don't see these ones be out of position for as long in a case where people have had this happen chronically. People also, if they've had it happen a bunch of times, they kind of know how to pop it back in themselves a lot of time. They'll be like, yeah, I just like shoved it back into place or whatever. So it's easier to do that if the structures around it are more lax or more unstable in through there. All right, enough about that. I know that can make some people feel a bit squeamish thinking about like things being a little bit out of position and stuff like that. So I'm going to move on from talking about that. But I do want to talk just for a second about imaging, because ideally, even if we have a patellar dislocation where it pops out and it goes back in on its own, we should still have imaging done of that injury. So Maybe you don't need to immediately go to the emergency department if you can like bear weight on it and things like that. Some people will go to emerge right away. Maybe you wait and see your doctor the next day and get x-rays, like requisitions that way. But we do, in an ideal scenario, want to have some imaging, because with patellar dislocations, there's a really high likelihood of having some sort of a kind of fracture associated with that. And sometimes that fracture occurs as the kneecap pops out, and sometimes it can occur as the kneecap pops back into position as well. And these aren't huge fractures. It's not like a fracture right through the middle of the patella necessarily, although that can happen. But often what we'll see is little like kind of like bone chip type fractures or things like that. Or there can be damage to the cartilage. The underneath side of the kneecap is like made up of cartilage, and there can be damage to those cartilage surfaces of the kneecap. So we do want to know if there was damage that happened to those structures, either when the kneecap dislocated or when it was relocated. So this is an injury. In a lot of injuries, imaging doesn't like change the outcome necessarily, and it doesn't really make a huge difference in terms of like diagnosis and things like that with whether people have the imaging done or not. But in a case of patellar dislocations, this is a time where I do recommend people get imaging done, just so we know if there was any sort of structural damage, because that's going to influence the rehab a little bit in terms of like how conservative or how aggressive we can get with the rehab of these injuries. So it is one that we do recommend, and especially if it is a first-time dislocation and happened from like an acute mechanism. If it's something that, this person has a chronic instability and it's happened a whole bunch of times, we probably don't need to rush out and get x-rays the same way. But in that case, imaging may be important, and maybe in this case more so like an MRI, to look at, okay, what's the damage that's happened to the soft tissues around that? There's a ligament that holds there's more than one, but one of the ligaments that holds the kneecap in place, it can actually get like sort of fully torn. And if that happens, that's going to leave that person more susceptible to these chronic dislocations. So at minimum, we want an x-ray to make sure that there's no like bone chips or fractures happening. And in some cases, we may actually be looking at wanting to have an MRI to see what the soft tissue damage is, or the cartilage damage if there happens to be damage to the cartilage structures of the kneecap as well. So imaging is something we do often recommend with patellar dislocations. In terms of like signs and symptoms, like what will people kind of report or sort of complain of, or things that they'll tell you about. And this is especially if it's not like a dislocation where it stayed dislocated. If somebody dislocates their kneecap and it doesn't spontaneously reduce, I promise you will know that that's what they did, because it will not be in the right position, and you'll look at their leg and you'll be like, oh, your kneecap is not in the correct place. It's like off to the side. So those are probably pretty easy to be like, yeah, that's 100% what that injury was. But in the case of these subluxations or a dislocation that spontaneously reduces, sometimes it's a little bit less clear what the actual knee injury is. So things that a dancer might sort of report to you, if you're, say, a teacher and they've injured their knee, sometimes they'll report that they heard like a click, like a pop, or sometimes they'll like report it more as like a clunk, or like something that was like, a noise or something that happened in their knee at the moment of the injury. They will often report a feeling of like, it felt like my knee like shifted and then came back into place, or it like buckled and then came back into place. Like there'll be some sort of a description of like, kind of like shifting, buckling, instability, things like that. They will sometimes report like locking of their knee, like they'll feel like they can't move through a specific range of motion. And sometimes people will even be able to localize that to their kneecap, and they'll be like, it feels like my kneecap gets stuck in a certain position. So that can be something that they may report. And then in terms of the pain is generally fairly local to the kneecap. So if it's an injury to other structures of the knee, sometimes people aren't as able to localize it. Like they might be like, oh, I don't know, it kind of feels like it's like inside the knee, or maybe the like, medial part of the knee or wherever. But with like patellar issues, like dislocations and subluxations, almost always people will say like my kneecap. And a lot of times people like again, like almost instinctively know that that's what happened. Like they'll come in and say, it feels like something happened to my kneecap. And then you like assess and you're like, well, something did happen to your kneecap. So the pain is often usually pretty localized. There's often a significant amount of swelling. Again, especially if this is a first time dislocation, you can assume that there's going to be like a decent amount of swelling. If they are one of those more chronic dislocators or subluxers, they may actually have stretched things out enough that they don't get as much swelling when it's happening like the second, third, fourth time. So it depends a little bit, but certainly if it's a first time one, we often expect to see a lot of swelling. We may see bruising associated with it, but I would say I less commonly see bruising with these. Sometimes you do, but it's not always a given, but definitely swelling and oftentimes, sort of maybe more swelling than you would assume for like that type of an injury. So that's kind of things you might sort of see or dancers might report. In terms of like treatment, like what do we do to deal with these? What do we expect in terms of healing timelines and stuff like that? It depends a little bit on the amount of damage that was done at the time of injury. So in a really straightforward dislocation where we don't have like any sort of fractures or bone chips or anything associated with it, and there's not really significant damage to the soft tissues. Again, like there's always going to be some damage, but it's not super significant. We're usually looking at about a 6-week recovery timeline in terms of healing for those types. But if we've had any sort of damage or injury to the cartilage or more significant damage to the ligaments or tendons or things like that, these can be much longer than that. And they often say like 3 months or so in kind of the literature, like when you look at like, kind of sports medicine textbooks and healing timelines. But I will say in reality and practice, especially if there's been damage to the cartilage, it's longer than that. It's probably more like 6 months before dancers are like 100% back doing everything. That's not to say they can't gradually get back to doing things, but certain things like direct pressure through their knee, so certain floor work activities often take a really long time to get back to. And there can be like a few other things as well, but it's not uncommon for dancers to like, even 6 months down the road, just be like getting comfortable. So depending on the style, like if it's a contemporary dancer who's doing a lot of like floor work and a lot of really deep work, or even like hip hoppers where there's a lot of like really grounded kind of like deep knee bends or breakers where they're having to like spin on their knees and stuff, it can definitely be much longer than 3 months. But I would say on average with the kind of a typical one where there hasn't been a lot of like cartilage damage, we're looking at anywhere between 6 weeks and 3 months, depending on, again, sort of the severity of the dislocation. Again, if these are people who have had chronic dislocations, the recovery is usually much quicker. And some people will be like, oh yeah, my kneecap just like popped out yesterday, but it's fine today. And you're like, well, is it truly though? Like it might feel okay, but it's definitely still unstable in through there. So again, sometimes we are needing a more permanent solution for those, but there's usually less like acute tissue damage associated with those chronic ones. So that 6 weeks to 3 months is usually for that acute patellar dislocation. In terms of like, what do? We are often bracing these to begin with and just using like a patellar stabilizing brace. Again, if there's fractures or a lot of like cartilage damage, we may be immobilizing these in like a knee brace that doesn't allow their knee to flex. So we'll keep their knee fully straight for a certain amount of time. To start with, just to like kind of try and allow the most amount of healing, especially for that cartilage. But in most cases, that's not necessary, but we are looking at, increasing and improving their stability with a patellar stabilizing brace. And we will often use those braces right the way through return to dance protocols. So in some injuries, by the time dancers are like returning to dance, we may not be using like supportive bracing and things like that anymore. But with patellar dislocations, it is often something that we are incorporating back into their return to dance. And then when they get to the point where they're strong enough and stable enough that they maybe don't need the brace for dance anymore, we'll usually transition to taping to control the patella or just give them a little bit of extra proprioception and support in through the patella. And so they'll often tape it for a while, even when they return to dance. and then eventually like not need anything. But it's kind of one of those things that people will often ask, well, do I need to have a brace? Like, do I need to go out and buy one? And usually the answer is yes, because you're going to use it in those early stages of rehab for protection, but then we're also going to use it for kind of return to dance progressions and things like that. So bracing, definitely. The big thing with patellar dislocations is working on strengthening. So dancers will often lose a fairly significant amount of strength pretty quickly because, like I said, these tend to swell a lot. And oftentimes with knee injuries, if we have a ton of swelling, the muscles in the legs and especially the quad muscles become a bit inhibited, and they'll kind of like shut down a little bit and just not be as efficient as we want them to be. So we are often working at, obviously, we need to reduce the swelling, and that is kind of like first line of defense. We want to really try and like minimize swelling as much as we can and get that circulated and away from the injured area. But then we also want to really work on getting all those muscles firing again and getting them all back online and really working on strengthening, because ultimately these injuries can become injuries of instability, like we talked about, if we don't rehab them like kind of properly the first time around. And so that comes down to loads of lower extremity strengthening stuff. And not just the quads, but also obviously hamstrings and glutes and our outer hip muscles and like our adductors, all of those muscles that kind of like support and influence the lower leg mechanics in through there. So rehab for patellar dislocations is very strengthening heavy in terms of like what we're looking at. And then for sort of return to dance protocols, we're often basing those off of where they are in terms of their strength and then range of motion as well. With these injuries, people usually can straighten their knee pretty easily, but it's when they get to deeper ranges of flexion. So like for an example, for a return to dance protocol, we might have dancers who are going back and they can actually do like quite a lot, but they may still struggle with like grand plie type or like really deep squat type activities, but they can do, shallower squats. They might actually even be able to tolerate jumping and sort of things like that before they can get into the really, really deep knee bends. And that's partly because when we bring the knee into full flexion, and especially like weighted full flexion, like a grand plie type position, there's a lot of compression force that happens through the patella, like through the kneecap area there. And that can be a little bit irritating to people depending on like where they are in their stage of rehab. So definitely strengthening, but also looking at that range of motion and kind of trying to get that tolerance to full loaded flexion positions in through there. All right. And the last thing I want to talk about just super briefly is surgery. So like I said, especially with the chronic instability, we often are looking at a surgical intervention as a long-term intervention because these will just become like worse and worse and worse over time to the point where people can be like walking down the street and it'll pop out of place or like things like that. So oftentimes in those cases, they are looking at a surgical stabilization. So they'll go in and they'll sort of tighten up all of the structures around the kneecap to create that stability so that it's not kind of like popping out of place as often or hopefully ever again. So surgery is definitely something that we do see on the table for these more chronic patellar dislocations or subluxations. It is not as commonly needed for the acute ones, although sometimes people will have to go down that route if they've had an acute dislocation and there is, potentially a big fracture associated with it or something like that. But generally, when we're looking at surgery, it is from these more kind of chronic instabilities that develop from repeated subluxations or dislocations. So if we do have a first-time acute knee dislocation, it's really, really, really important that those dancers rehab their knee like really thoroughly. So we really want to try and make sure that that injury that happened is a one-time injury and does not become a chronic injury in through there. So if you are a teacher or if you're like a dance parent or whatever, sometimes it's easy to like, I don't want to say brush these injuries off, but people might like go get it assessed. Maybe they go to the hospital, they find out what the diagnosis is, they get it assessed, they're told to go to physio, they maybe go for like a session or two, and then they're kind of like, okay, I can slowly get back into my activity. After like 6 weeks, they're kind of returning to dance, but they've maybe not addressed the strength around the knee. So potentially they're compensating, or things just like aren't as strong or as stable as they should be. So they're leaving themselves vulnerable to this happening repeatedly, or a second time or a third time. If we can make sure we're doing really comprehensive rehab the first time around, so the first time this injury ever happens, we can prevent a lot of these from becoming these chronic instability type injuries, especially if there's no underlying instability, like if the person isn't kind of hypermobile or things like that, and it was just like truly an acute injury. We really want to make sure that we are doing appropriate and really comprehensive rehab so that it is a one-time event and it does not become an ongoing thing for them. So if, like I said, you're a teacher and you have a dancer who has this type of an injury, it's really important to like make sure that you're really promoting them going through the rehab process and like being diligent about participating in the rehab, because these do have such a potential to become a more chronic or sort of like long-term issue, which nobody wants. So I think that's all I have to say about patellar dislocations for right now. If you have questions, comments, concerns, want any clarification on any of that, please reach out. You can reach me by email. My email is in the show notes. Or you can reach out on social media. I am Dance Physio Erika on Instagram and Facebook. Instagram is a better place to message me. I feel like I miss messages on Facebook all the time. If you found today's episode helpful, if you know anybody who has ever had a patellar dislocation or subluxation, or anybody who you think might find this podcast episode helpful, I encourage you to share it with them. The more we can spread the knowledge about appropriate rehab for these types of injuries, the better. And yeah, I will leave it there. And thank you so much for listening. I really appreciate your support, and I hope you have a great rest of your day.